She goes, I wouldn't even discuss this if I were you. It's not that you're stupid. She said, that's obvious. She said, you just have focused knowledge. And so I said, well, thank you, Emily. I wish yeah, I'm focused knowledge. I know what's not spine. That's going to be part of your business too. Part of being a physician in our business, people come to you with musculoskeletal problem. Well, if they've got back pain, you don't pick up a ureteral calculus. You don't pick up a kidney problem because you're examining their back. You haven't done for CVA tenderness. You haven't done your job. You guy comes in and says that he's not walking right. Well, if you don't know what's causing their ataxia and send them to somebody and see them back after you send them to somebody, you haven't taken care of your patient well. And it's not a little different in a county orthopedic clinic if you're seeing 75 people one day, but still, and you can't get the referral back from wherever you send them to, but in your practice, it's critical that these other things are going to show up with musculoskeletal problems all the time. So we've done, now look to the left as far as you can, look to the right, so you got to record the range of motion, neck back like that. We've done muscle strength sensation, the peripheral tunnel syndrome, superficial radial nerve is here, numbness and tingling in that area. There's a good book, there's several good books, little handbook things about these peripheral nerve entrapments that you can pick up pretty quickly. Okay, now we're going to do the low back exam. Lay up here on the table for me. That's good. Now this is the way I can tell you how many patients Larry Dorr and I have treated down through the years. So the other thing besides neck and shoulder that you see as orthopedists is back versus hip. Absolutely, constantly. The most common referred pain area, and I'll show you on the cervical spine, the most common referred pain area for lower back, posterior spear-like spine, right there, sacroiliac joint. That dimple right there is referred discogenic pain from your back. We know that because guys like Bert Mooney took patients and inject them with irritating things in their spine, and they saw where the pain went. That's not radicular pain, it's referred pain. So referred pain right here across the brim out into that area is the most common referred lumbar pain. So people present with hip problems. Some guys got sciatic in the leg. Well, you relax your sciatic nerve by rolling your leg out. That relaxes the nerve. So some guy's been walking like this for 6 months with his leg out. He comes in with a hip problem. It's not a coincidence, right? So you can get a lot of combined problems with that too. Guess what the miracle test for hip problems is? Check the range of motion. And so you're going to do external and internal range of motion on both hips. And the key test is the Faber test: flexion, abduction, external rotation. You do this test, let your leg come down to the table, and they have groin pain. They've got a hip problem, not a back problem. And that's the test, just like the shoulder abduction that you got to know. Faber test. Hip, if they have pain there, well, I'll put it this way: they need a hip workup. That doesn't mean they don't have multiple sclerosis, but they've got a symptomatic hip problem. Now, Dora tells me that you can get a hip problem that hurts posteriorly with that test. But back problems hurt posteriorly all the time. If it hurts in the front, they get a hip workup. If they have a normal range of motion and hurts in the back, it's a back problem. I don't worry about that too much. Now, the other test for sciatica, just like the Sperling's test, is the cram test or bowstring test. So we're going to do a straight leg raise. This is the way I check the straight leg raise supine. So I've done hip range of motion. Now I'm going to do the Sieg test, which is extension of a flexed knee, extension of the knee on a flexed hip. And so we're going to straighten that out now. Does that reproduce back pain? Do you have pain in your back? Do you have a crossover straight leg raise that's hurting in the right buttocks when I raise the left leg? That's a sign of extruded disc fragment, crossover straight leg raise. But you got to remember the pelvis is rotating some when you got them in this position. So I'm going to straighten this out. Does that produce pain down your leg? Second thing you do is the cram test is the second structure in. Hamstring tendon, sciatic nerve, right there. Some people are more prominent. That's his right there. You got a bad problem. So if you push it on your sciatic nerve and it goes up and down the leg, that is the pathognomonic sign of sciatica. You're not pushing on the hamstring tendon, you're pushing on the sciatic nerve. You can feel that nerve sitting where you are in that position. If you sit where you are, put your feet out in front of you, bend forward like this, feel your hamstring tendon, the second structure ends the sciatic nerve. I've got mine are both prominent on both sides. You can feel that nerve. And so you push on that. You're not pushing on anything else. That's not hamstring tightness. That's not anything else. It's there. And then so you check that, and we check that. We check for that symptom. And then you always take it all the way down and bring it all the way up straight. A low S1 root disc herniation, L5 S1 herniation, S1 radiculopathy. You know, a low radiculopathy sometimes will hurt in the first 30 degrees and become negative after that. So that's one of the things, you always bring it down and bring it all the way up and recheck. I normally do this in the sitting position, but what are the distributions of radiculopathy in the leg? We talked about the arm, and the autonomous zone for the arm I didn't mention, C5, is right out here in this area and that thing. So what are the typical patterns in the leg? I worked at a very innovative place in Oswestry. Street. It was a small hospital up on the Welsh border. The ODI, the Oswestry Disability Index, was created by Jeremy Fairbank and John O'Brien, two friends of mine. And it is the #1 most used functional test of pain and disability in orthopedics for spine worldwide. Oswestry Disability Index is the name of the town where the hospital was. And they also took 300 Welsh farmers, disgusting naked pictures in underwear of 300 people up on the Welsh border. It was a disgusting group of pictures. And what they did was they correlated the pain distribution pattern to the myelogram and myelogram, not MRI that time, the myelogram and the MRI and CAT scan as to where the herniation, what nerve it was. And all they could come up with was C3 and C4 are the front of the thigh. 3 normally stops at the knee and comes down, and 4 will come down in the medial shin. If you look at most of these pain, pattern books and stuff like that, C4 crosses the shin, down in the medial shin, down to the medial malleus like that. So, and 3 stops at the knee. 5 comes down lateral calf, top of the foot, and big toe. S1, back of the calf, lateral foot. Back of the calf, heel, and lateral foot. Those are pretty reproducible patterns. Sometimes people are a little off, but that tells you, based on the exam, weakness, foot dorsiflexion, weakness is C5, L5, roll on your right side for me. The other, if you've got a weak anterior tib, what are the causes of that? Perineal palsy, right? You guys got fractured knees and stuff, perineal palsy. Well, what doesn't get weak with that is do your leg straight up to the ceiling. Is the hip abductor. Don't let me push that down. So if you've got a strong hip abductor and a drop foot, you're more likely to have a perineal nerve palsy. If you've got an L5 radiculopathy and you've got a drop foot, you're going to have a weak anterior tib. A hip abductor. You're going to have a weak hip abductor. Relax. The hip abductor's job is that when you stand on that foot, that muscle contracts to level your pelvis. So an NHL guy, he's got a weak, he can handle a weak anterior tib or EHL because he's got the big boot on. He goes on one leg, he instantly knows if he's got a weak hip abductor because he's not losing his balance on one skate. He goes on one skate, he's got a weak hip abductor instantly. They know. And so, but most people don't know that particularly. They get a sensation of dragging their leg. It's what a hip abductor weakness will give you. Now, the other test is a reverse straight leg raise for L3 or L4, and you do it like this. You take this back to neutral, and then you flex the knee. If that produced tightness in the anterior thigh, that's an L3 or L4 straight leg raise. Okay? And then do the hip abductor test. Go ahead and stand up for me. I always have people stand and say, face that one. That's good. Where does it hurt? Always have them put your hand like right there. It hurts right there. Does it hurt in your posterior sphenic spine? Does it hurt in the gluteal notch down here? Does it hurt in the greater trochanter? Does it hurt in the midline? Do you have CVA tenderness? The referred pain patterns in the neck are C4, C5, C6, C7, right down the medial bore of the scapula. So the other thing we see with the sports guys is they've got a scapular problem. They've got a shoulder problem. They've got a, you know how to check whether the scapula moves when you do this. I used to know that stuff, but I don't pay attention anymore. Whether the scapula's moving properly with your arm and all, because the referred pain from your neck, you push on a guy's head and it hurts there, you got a neck problem. Because that's a referred pain area coming down that area. Trap pain up here can be really, really difficult to deal with, and it's tough referred pain pattern, usually cervical, tough to deal with. Gait pattern, it's going to do this for me, just do a heel and toe walk, right across, looking out the window, there you go. Tandem gait, no, one foot right in front of the other like that. Look out the window. All right, he's done. So that, the tandem gait, you know, that's a workup for ataxia. In spine, that's a big part of our deal. We've got to know who has myelopathy. We can handle a C6 radicular problem, we can handle carpal tunnel and all that. Guy's got pressure on the spinal cord, he's got a big plexus cord, he's got MS or something like that. Then that's a big deal. Doing these reflexes, a guy with ALS that has global weakness and weakness in his hands, anybody with weak but floppy hands, you know, he's got awkward hands. He can't do buttons and hands. Normally that's C4 or above. But that's one of the things you have to evaluate in your stuff. So in summary, kind of, if going over the exam, these are the type of things, that, especially the Faber test and the shoulder abduction test, that you got to do for shoulder and hip problems and pick those things up. Know if a guy's got a restricted range of motion. I can't tell you how many people get back surgery for an arthritic hip. It happens all the time. And sometimes hip surgery for lumbar radiculopathy too, but usually it's the other way around. And don't be that person. You can do that by doing this basic examination. It's not that important.
Could you do spondylolysis really quick?
Yeah.
Spondyval, because that's going to be young athletes. That's going to be.
Yeah, spondylolysis is, oh, damn, I forgot. Thank you very much. I forgot the key part of the test for spondylolysis. Stand right here and face that way. Okay, bend forward and stop if it hurts. So forward flexion typically doesn't hurt with a spondylolysis. More likely to hurt with discogenic problems, and because bending forward and sitting builds up, has more intradiscal pressure than standing and arching back. Now arch your back as far as it goes. Grab their legs down here like that and arch your back, straighten up. If that hurts, then you have them do a single leg extension test. Stand on the right leg only and arch your back. If that hurts, especially on this side, if that hurts, the single leg extension test is the test for acute spondylolysis. That is the test. Sometimes it won't hurt because the lysis has calmed down, but that's the test for spondylolysis. Forward flexion discogenic, arching back, single leg extension test for acute spondylolysis.
Not unlike the spine test for cervical.
Huh?
Not unlike for cervical.
Yeah, just that similar thing. And so, in pain up in this area, in thoracic spine areas, radiation right along a rib, those are all things you're going to pick up by looking at their back and them telling you where does it hurt. Where does it hurt? Bowel, bladder, sexual function. I mean, when I first went to practice, Carolyn's passed out because I did a perineal examination on this woman in the Carolyn Joe Clinic the first month I was there. That was also the last one I ever did. Basically, I just said, look, you have any problems with bowel, bladder, sexual function? Can you tell you're going to the bathroom? Can you tell when you're wiping yourself? And usually with Cauda-Equina syndrome and pressure on the nerves in your back, what happens is you don't empty your bladder. It's not that you're losing it, it's that you're not emptying your bladder. So the question is, how many you go too little too often? How many times you get up in the middle of the night? Guy tells you he's going every 2 hours and he's got a back problem. He may have a 1,000 cc bladder there. And now they have ultrasounds, you have to do cath and stuff, but to sort that out. So my bowel, bladder, sexual function thing is basically that. Question urinalysis, question sensation, and if they have a problem, guess what? They go to the urologist right away. We got guys that see them pronto. And the other thing we do with these athletes, when they come into town, they fly in from New York for a workout. We got block time on the MRI unit, the SPECT scan, the CT scan. The EMG is a little tougher for us. Our guy comes on Monday. But we do all the testing and give them an answer about 5 o'clock and document it. So I had one guy one time, I told him you probably have a spondylolysis. He went back to town, and the write-up on the sports page in the Cincinnati newspaper was, the doctor in California missed my fractured spine. So I don't miss many anymore because we do all the testing that day. So that's a little harder, but that's part of the package of seeing these guys, and then manage the rehab. When I was here, rehab's a famous USC thing. When Paul Harvey ran the county here, and Vernon Nickel ran Rancho, it's a great tradition that y'all are part of. They did all the acute care here, and all the rehab went to Rancho. If you made rounds with Harvey, and he always remembered a patient you had in the hospital sent to Rancho, he wanted to know the status of that patient. What's going on? Where is he in his rehab program? And so that connection, and also at Rancho, remember, they had no physiatrists. There were no physiatrists there. It was run by surgeons and physical therapists. Jacqueline Perry, surgeon, and all her people were physical therapists. So that idea that the surgeon works with the physical therapist in the rehab, for me, started right here at County Hospital in Rancho. And that's a USC tradition. Physiatrists and all that never happened before. It's probably different now. But so being able to manage the rehab in your orthopedic patients, obviously I think it's a critical factor. You'll have a cadre of physical therapists referred to. We give a course once or twice a year for 200 to 250 physical therapists.